Hello, this is Mike Hines, and welcome to another episode of Modernization Accepted. Normally, I'm your host for this show, but in this episode, I'm actually the guest for Dr. Kevin Foe's podcast, Kevin MD. Kevin MD is one of the most influential podcasts in the healthcare industry, and he is regularly quoted on the Wall Street Journal, CNN, and the New York Times. We were honored to be invited to his show to talk about the implications of COVID-19 to healthcare technology.
Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today we welcome Mike Hines. He's an evangelist at Resolute Software. Today's Kevin MD article is titled How COVID-19 Unleashed the Power of Microservices and Container-Based Solutions. Mike, welcome to the show.
Well, thank you very much, Dr. Poe. I appreciate it.
So tell us your story and journey to where you are today.
Well, my background is all technology. I spent about 10 years at Microsoft doing education software, 10 years at Amazon, mostly with gaming software. I've done a handful of startups on education and cutting-edge game technology, collected a handful of patents, and then retired to a tree farm in Georgia. After retiring to a tree farm in Georgia and finding trees not exactly thrilling conversationalists, Resolute Software found me and gave me the opportunity to do a deep dive into the technology supporting healthcare. And this is great because I get a chance now to invent new processes, new services, and new software that will help fulfill the promise that technology has always had for healthcare and healthcare outcomes. From a guy who almost went pre-med as an undergrad, I had to jump at that chance, and that's kind of how I landed here.
Perfect. So you've had a background outside of healthcare. You mentioned things like Amazon and Microsoft. So now that you're in healthcare, what's specific about the healthcare field, the healthcare IT field, that makes it different from some of the other things that you worked with in the past?
Oh, absolutely. In the past, I've worked with people who have been very much technology forward people. Amazon and Microsoft are all a bunch of technology people working in technology. The game developers I work with are all technology people working in games. Healthcare has been really different. There are a whole bunch of doctors working with patients and administrators working with doctors. And IT, the technology side, has almost taken a back seat. And it's fascinating to kind of see the conjoining of clinical work and technology work in impacting patient outcomes. And I think that we're at a fascinating juncture where that's possible.
So a lot of us physicians often don't know what goes on behind the scenes on the technology side. And I talk to a lot of tech specialists as well. They don't know what goes on in the clinical side as well. So what's something that you want clinicians to know about that tech side of healthcare that ordinarily that they wouldn't know about?
Actually, this ties in really well to one of the reasons I wrote the article. We have a whole bunch of unsung COVID heroes out there. First responders deserve every bit of credit that they get, but healthcare IT departments, they've made some miracles happen almost overnight. There was a price to pay for some of the miracles they pulled off, and my article calls out those miracles and the price they paid. But I'd really like clinicians to understand that your IT staff doesn't hate you. They're not doing any of this to get back at you. They've got the IT staff, they have patients too. And sometimes patients have good days and sometimes our patients have bad days. It's understanding will get you a lot farther than reproaches will when something doesn't work on the IT side.
So let's talk about your Kevin MD article, How COVID-19 Unleashed the Power of Microservices and Container-Based Solutions. So you talked about some miracles behind the scenes when it comes to IT during COVID. Now, tell us more about that as well as your article.
Oh, absolutely. And it all starts with kind of the backstory to COVID. Up to 2021, a lot of IT staff had been staffed and budgeted to make sure that things like scheduling servers and billing servers worked well for the staff and the clinicians, and they were getting into doing some electronic medical records, EMR management. Then COVID hit, and all of a sudden there's a mandate to reduce physical contact, to do social distancing in healthcare. Seriously, Imagine, imagine Kevin trying to get your car repaired, but you're not allowed to let the mechanic into the room or into the garage. That's ridiculous. But IT, the doctors and the tech staff, they work together to kind of figure out how they can do a lot more of these things remotely. And certainly there has been some prior effort in getting remote measurement out there, but that really ramped up due to COVID. From older tech like cholesterol testing, colon cancer screening, and the sleep apnea testing to kind of more real-time pacemaker monitoring, glucose monitoring, body temperature reporting, blood pressure collection, and data. That all got really accelerated. Now, all of the data that's been collected, in this example, this collected on the remote monitoring devices, well, a patient can't just bring that into the clinic.
Yeah.
I mean, there goes social distancing, right? So it's got to be entered online. Well, enter your local IT staff. If you have a chain of clinics, then you've got to develop a web page, a way for them to enter the data, a way for that data to get injected into the electronic medical record. It's all got to be done within HIPAA compliance. That's a whole nother story, IT and HIPAA compliance. We'll write that article later. But overnight, the IT department created these pages and discovered that, sometimes patients aren't the best at actually recording all of that data and reporting it online. So they had to go an extra step. They had to help patients connect those devices to their home networks and then get those devices on the home networks to call back to the clinic, get into their network, and get into their electronic record database to actually enter that data into the EMR. That's huge because up until 2021, the only thing these server stacks have done is manage billing and appointments. Now, all of a sudden, that same infrastructure has been pressed into service, managing thousands of connections from devices on remote networks, all want to insert data into your database. It's no surprise that was stressful for a lot of network infrastructures that existed to do billing and scheduling. By the way, this is kind of the definition of technical debt when you skip critical digital infrastructure improvements to deploy critical technology. When I spoke to IT departments at the HIMSS conference in Chicago, a lot of the IT administrators that I talked to said that they wouldn't deploy it this way if there really hadn't been that emergency. But deploy it they did. They got the miracles done. It worked. And everybody loves the remote monitoring. And nobody wants to give it up. So they can't go back and undo everything and then build out the infrastructure correctly. This is sort of like the new normal, and it's not going away. And they've got to try to replace a flat tire while the car's still moving.
So take us into that time during COVID, and you were working, of course, in healthcare IT. Give us a little story or an anecdote that really illustrates how you had to deploy some of these technical solutions before you were fully comfortable doing so. Just give us a little anecdote from your world during that time.
So the big challenge is the migration of architecture technologies on the back end. When you only have one or two systems to maintain prior to 2021, you could go ahead and write those all on top of the same collection of server technologies so that you have a server program that will access scheduling, a second bit of code that you add on to that does billing, and you keep adding additional parts to this one piece of server code, and you end up with what we call monolithic code, which is one gigantic chunk of code that's trying to do, half a dozen different things. As long as those things aren't particularly stressful to the system, and as long as they're all kind of similar things, you can run your website and scheduling and billing all off of the same server and all off the same server stack, and it's not really that stressful. Asking remote devices on different networks now to connect to your network and get direct database contributions for their data, that's a huge difference, and it's a big weight. Normally, outside of COVID, you would want to make sure that you can break some of those services apart so they run independently of one another, and each gets the services that they need to run independently. But that kind of time and that kind of budget wasn't available for COVID. So people started building these extended contact-free services on top of the existing stacks that they had, and with predictable results. We have an IT staff that has just created these miracles, but it's on a house of cards, so to speak.
Yeah.
So they would spend most of their time actually trying to keep that system up and running, and all of a sudden new deployments and new implementations became really problematic because they were spending a lot of time restarting servers. And trust me, as a clinician, nobody understands why the server is going down. They just know that they can't access the medical records that they're used to accessing. So all of a sudden, IT gets a call from a very angry clinician thinking, where's my data? Where isn't it? Why isn't it working? These poor guys.
And trust me, I've been that angry clinician on the other side of that call many times. So it's pretty important to get that perspective. Just give us a contrast. So under normal circumstances, how long will it take to implement a solution in an optimal setting as you describe? And how much was that time compressed during COVID? Just to kind of paint a little bit a clearer picture.
Oh, certainly. Before COVID, what you could do is you could take the services and you could take the time to copy one of the services in your monolithic stack, copy one of those services to a smaller deployment, say one that only contains that service. I mean, you could call it a microservice. We do call it a microservice. And we give it a little bubble to run in, a little container to run in that has all of the required bits that it needs to operate, a microservice inside a container. And we can test this and make sure that it gives us the same results as the existing monolithic service does. And if we get the same results, then we can create lots of little copies of this container with this microservice, depending on the load that it's getting. More load, you just create more instances of the containerized microservice. And next thing you know, you can go ahead and stop the calls to that part of your monolithic service and transfer those calls to the individual microservices. When you get more traffic, you instantiate more instances of the service. And if one little bubble, one little container fails and crashes, nobody's going to know, because you have all of these other instances that can share the load until that little guy gets rebooted. And the service goes on as usual, and none of the other services is impacted. So you do that for one, and then you do that for all of the services that you have in your monolithic stack. And the next thing you know, all of your services are now collections of containerized microservices. And you have a very resilient system that can take a lot of change in demand and traffic, and it can suffer a lot of impact and failures without anybody actually seeing that anything's gone wrong. This process can take 6 months to 9 months to tease out, depending on how big your monolithic stack is. The COVID compression turned that into, what can you do in the next 30 to 60 days?
Wow.
Because we can't have lines of people coming in all waiting to sit down on one of our beds and get their tests done. We have to go zero contact. What can you give me by the time our patients need their prescriptions renewed? Yikes.
So here we are 3+ years after COVID. What's the current status of the majority of health IT solutions? Are we still building on top of legacy architecture? Are we unwinding and doing things the way it's supposed to be done? Just kind of in general, give us the status of what health IT companies are doing.
I wish there was a majority. It's really hard even to say that maybe a plurality would be 30%. It's all over the place now, Kevin. And the problem comes back down to the heroics that we saw people doing. A lot of that is still built on the old infrastructure. And because the staffing is still built around scheduling and billing, they don't have the people they need to actually go ahead and tease out those services into microservices and containers. And with their staff now busier than ever trying to keep everything standing, deployments of new technology are kind of slowing down and kind of much more difficult. So if you've asked your IT department to deploy a new service or make an update, say, to the website, you're probably getting a lot more pushback now than you did before COVID for precisely that reason. Now, some of the larger institutions, your Kaisers, your Mayos, hiring a couple dozen people to actually solve that problem for them is a lot more realistic. So they're probably farther ahead of the curve, and they're probably already on the curve to containerized microservices when this whole thing started. It's the medium-sized collection of clinics, your regional multi-clinic operation, that is really suffering the most. They have the greatest need out there for that kind of resilience, but they haven't increased their IT spend or brought anyone else on board to get that done. So it's tough finding the way forward without actually committing additional spend or resources.
So what kind of lessons have health IT companies learned from the pandemic? You said that they're able to compress what normally would be a 6 to 9 month deployment in about 30 to 60 days. In the future, do you feel like new health IT deployments can be accelerated because of the lessons learned during the pandemic?
Certainly they could be accelerated, but I think we've also learned that that's a really terrible idea unless you really do have an emergency that threatens interruption of clinic services. And we're paying the price for that now. And technical debt is hard. It's kind of like high blood pressure.
Yeah.
You don't know anything's wrong until you get some sort of a catastrophic systems failure, right? So, unfortunately, a lot of people are leaving their IT high blood pressure untreated. And another thing like COVID's going to show up, and it's going to not work like it did last time because they're still sitting under that technical debt. So I think if we've learned sort of an institutional lesson out of this is miracles come with a price to pay. And it's time for us to pay the piper on that and get to that level where we have containerized services. Now, the nice thing about this is it was probably going to happen with or without COVID. COVID just sort of accelerated everything and gave us sort of a critical failure point. But the reason this was going to happen anyway is because when you have a system, an architecture of containerized microservices, adding new services is a lot easier for IT and a lot less risk for the system, because you can take a new service, put it in its own container, try it, and if it crashes and burns and is a horrible disaster, none of the other services that you currently rely on for your day-to-day clinician work gets affected. It doesn't take the whole system down. It just takes down its own little container, and you get to troubleshoot that and fix it. And when you deploy it, again, you can scale the number of containers you have to the right load. It becomes a lot easier to maintain and deploy additional new services. So that's really kind of the lesson I want IT administrators to take out of this or clinician administrators to take out of this for IT.
So just to reframe it, the short-term benefit that we gain from that rapid deployment in COVID is leading to some longer-term problems going forward. And without a capital injection to fixes like Kaiser and Mayo's doing, you're going to anticipate further problems down the road.
Absolutely. It's not an unknown phenomenon. I mean, lots of companies will go ahead and deploy for the sake of competitive advantage before their infrastructure is really ready. They know they're taking on the technical debt when they do that. However, most of the companies that do that tend to be on the tech side of things and recognize and have a plan to address that technical debt after their technical, deployment is finished and their market advantage is established. I don't see that happening in healthcare past kind of the largest 5 networks, hospital networks.
We're talking to Mike Hines. He's an evangelist at Resolute Software. His Kevin MD article is titled How COVID-19 Unleashed the Power of Microservices and Container-Based Solutions. Mike, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
Well, first of all, I'd like everyone who's not in the IT staff of a healthcare organization just to stop and recognize the role that IT played in getting all of us through COVID and the social distancing mandates, all with a really impressive minimal loss of humanity. So just take a moment and say thanks to your local IT staff. For administrators, the take-home message is recognize the technical debt exists, then do something about it. If we don't do that, we won't have a miracle in the bag for the next COVID-like occurrence. For clinicians, boy, your IT team doesn't hate you. They haven't gotten angry at you. their patient is just having a really bad stretch right now because it's been overburdened with all of these other services that's got to get done. And it falls over and it needs to get picked up and restarted. And that's going to cause a little bit of instability for the practitioner side of things. But wow, understand how that's happening and that this is one of the prices that we're paying. And clinicians, encourage your administrators to help IT help you.
Mike, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Well, Kevin, thank you very much. I appreciate it.